So we move to the next presenter will be Professor Etienne Macedo from University of California, San Diego. He will talk about the effect of the ultrafiltration rates on kidney recovery post-acute kidney injury. Professor Macedo, please.
Thank you, Dr. Chai. It's a pleasure for me to be here. This is going to be my outline, so I'm going to talk about the evidence linking fluid overload and renal recovery, discuss the role of modalities, high versus low ultrafiltration, and also some perfusion-based resuscitation protocols. So we have data that is...
Speaking to Mike.
Sorry. That's more than a decade old, suggesting that the degree of fluid overload and IRT initiation can affect kidney recovery. This is a study with 107 patients with AKI requiring dialysis, and we see that the degree of fluid overload at dialysis initiation was an independent predictor of non-recovery. We also have studies showing the association between modality and recovery. Here, more than 4,000 patients that were propensity matched undergoing CRT and IHD. They were followed by a median of 3 years. And we see that the risk of long-term dialysis dependency was significantly lower in the group of patients that initially received CRT. And using data from more recent trials, here the ATN and the Renown, the authors evaluated the effect of initial modality and the IRT dependence at 28 days. They found that the CRT first was associated with decreased need for IRT dependence, and also more IRT-free days. So they confirmed the findings using different models and also adjusting for several factors. This is also a recent analysis of the STARK AKI, a complicated analysis. They generate a propensity score for the likelihood of receiving CRT. And they also found that compared to IHD, starting with CRT was associated with a significant reduction in the composite outcome of death and IRT dependence at 90 days, and also mostly driven by IRT dependence at 90 days. More recently, this larger retrospective cohort, 3,800 patients, AKI survivors at 90 days, and they showed that, as expected, the patients that were included in the IRT group, they were younger, they had less comorbidities, but they had higher severity of illness. And they also confirmed that CRT-treated patients were 30% less likely to be on dialysis after 90 days. So again, suggesting that slower and more continuous fluid removal supported a higher rate of kidney recovery. So for patients that are discharged on dialysis, this study included 100 patients. They evaluated the period of outpatient dialysis. Mostly they got information in the first week. They saw that 43% of the patients recovered kidney function, mostly at 30 days. And the factors that were independently associated with non-recovery were higher fluid removal overall in the first week, the rate of ultrafiltration, and also the presence of dialytic hypotension. So it may be that higher degrees of fluid overload and also the delay in achieving fluid balance leads to, as we know, kidney edema that compromises kidney perfusion and may delay kidney recovery. Also, patients that are more fluid overload, they are at higher risk of hypotension because we aggressively remove fluid at dialysis. And as we know, patients that are after AKI, they lost the autoregulation. So with episodes of hypotension, they are more likely to have repeated injury. So this study was an interesting approach. They used urine output as a surrogate marker for residual kidney function and also renal recovery. And they found that, as we would expect, urine output significantly decreased in the first 24 hours after CRT initiation. They had a very low NIUF rate, was 0.7 ml per kilo per hour. And as we see in the graphic, as the net UF increased, urine output decreased. And patients that had more fluid overload at dialysis initiation, the negative fluid balance gets the greatest decline in urine output. While the patients that have more negative, they had lower effect on urine output. But we see that based on the map, they were relatively stable. They also evaluated this vasoactive inotrope score. So patients were mostly stable during the fluid removal. And although we see that for every 1 ml per kilo per hour of fluid removal, they had a decline on urine output, that didn't reach statistical significance. And in addition, the pre-CRT fluid balance also did not significantly modulate this association between NAUF and urine output. So we can conclude that in this very conservative NAUF, this median 0.7, as I said, as we're going to see, it's low. Higher UF rates did not directly compromise the renal recovery when we measure based on urine output. Now analyzing UF during CRT and renal recovery within the MAKE outcomes, this retrospective cohort compared the incidence of MAKE in patients with and without volume overload, defined as more than 10% of cumulative fluid balance above the weight. And they confirmed that volume overload was independently associated with a 58% increase in the risk of MAKE. Here, when fluid overload was analyzed as a continuous variable, every 1% increase in fluid overload showed that non-significant 0.9 increase in the odds of MAKE. In this single center, it's a retrospective study, they addressed the same question and they evaluated net ultrafiltration based on fluid removal during the entire time the patient was on CRT, and they adjusted for the weight and for the number of days the patient was on CRT. And based on the median net UF of the cohort, patients were divided in low intensity and high intensity. So the overall mortality was high, 54%, and was significantly higher in the low intensive group. When adjusted by fluid overload at CRT initiation, higher intensity was associated with lower mortality and with the greatest effect on those patients that had higher fluid overload. And for MAKE, a higher NAUF was also independently associated with lower chances of non-recovery or mortality. So they conclude that higher UF net may mitigate the adverse outcomes that are associated with fluid overload in this high-risk population. So in this other study, using again data from the PRENOW, they evaluated the association between hourly ultrafiltration rate, again adjusted for body weight, and survival among patients that received CRT. So more than 1,400 patients, and they stratified low, medium, or high UF based on these parameters. And I'm not going to talk about the analysis for mortality, but they adjusted for multiple factors, and the attributable risk associated with high UF was significantly higher than the associated with cumulative fluid balance in this cohort. But I want to focus on this other study that also used the RENALV cohort in patients that survived. And they saw that kidney recovery was more frequent in patients with lower UF rate. And in this competing regression to time to independence for IRT, they also found that UF net more than 1.5, so higher group, was associated with a long time to independence from IRT and a lower probability of kidney recovery. And also, each 1 ml per kilo per hour increase in UF rate was associated with a lower probability of kidney recovery. So we see that there's some inconsistency in the results, and in this meta-analysis didn't help much. They included 5 studies evaluating this association of net ultrafiltration intensity and renal recovery in patients undergoing CIRT, and they found no correlation between the UF net intensity and renal recovery. And we can understand why, right? We can potentially have organ dysfunction on both ends of the ultrafiltration spectrum. On the left, a slower UF rate can prolong fluid overload, leading to organ edema. And on the right, a faster UF net increases the risk of organ ischemia, including reduced kidney perfusion. So it's becoming clear that we have this J-curve relationship between mortality and net ultrafiltration. With slower fluid removal, is better tolerated hemodynamically, but prolonged exposure to fluid overload and organ edema. And faster fluid removal can help we achieve a negative fluid balance, but increases the risk of dialytic hypotension and ischemic organ injury. But as Ravi very well explained to us, it's important to make the difference between machine-based NAUF, which is defined as the volume of ultrafiltration by the dialysis machine that is adjusted for body weight. It's different from what we might call net balance as proposed by Ravi. And in order to calculate the hourly, so the net balance, we have to ideally have hourly information and on the intakes and outputs of the patient. And the difference between this patient total input and output minus the net ultrafiltration of the machine, we would have the net balance, or what we can also call UF net. So now that we understand the difference between the machine and the patient volume, we can talk about the term precision net ultrafiltration that would refer to the process of adjusting the net balance based on continuous monitoring of the hemodynamic status through possibly integrated sensors at bedside, and with the goal to minimize hemodynamic instability and reduces the chances of prolonged or more kidney injury, by avoiding that we remove more than the capacity of refilling at a certain time point. So in this single center study, a perfused-based deresuscitation protocol was tested in patients with fluid overload more than 5%, and they compared 2 different time periods. So the first one, the control, fluid management was at entirely discretion of the clinician, and the other, the early dry group, when I standardized a perfusion deresuscitation protocol. So this was the protocol applied. They all initiated with a 2 ml per kilo per hour, but again, this is based on the machine balance. Every 6 hours, hemodynamic parameters were evaluated and the UF adjusted. So if the patient was still for fluid overload or the fluid balance was still positive, they would increase UF net. And if the patient reached dry weight or was hemodynamic and stable, UF was decreased. And here, comparing the early dry with the control group, we see that the cumulative fluid balance at day 5 was significantly more negative in the early dry group. Plasma protein concentration increased in the early dry group, so they removed fluid. And there was no difference in hemodynamic parameters, suggesting that the protocol didn't compromise stability. And so perfusion-based resuscitation approach can safely achieve a more negative fluid balance. That was the conclusion. And good news that we have 2 trials that are currently underway. One is the Relief AKI, and we are going to see the trial being presented tomorrow, so I'm not going to go through this. And another ongoing study is the Probe Fluid KRT. It's a multinational pilot to assess feasibility, and they are using CRT and IHD, but they have very clear parameters for adjusting UF rate. And the outcome is going to be initially the difference between cumulative fluid balance at day 5 in the intervention versus the usual care group. So in conclusion, multiple observational studies have consistently showed that when fluid overload exceeds 10% of body weight, patients have reduced chances of recovering after an episode of AKI. Aggressive ultrafiltration can rapidly correct fluid overload, but organ ischemia and intradialytic hypotension can delay or prevent AKI recovery. Factors such as time and intensity of fluid removal, as well as the choice of the RRT, can influence long-term dialysis dependence. And given the difference in patients' tolerance to fluid removal, protocols that dynamically adjust UF can optimize discongestion while minimizing hemodynamic instability. And we have trials that are coming to teach us how to do that. Thank you for your attention.
Etienne, thank you for a very nice talk. I have one question. People try to focus more on the ultrafiltration fluid removal, but also in the meantime, we also give some time in the clinical practice. We did not aware much in terms of the fluid intake. Then we give a lot of fluid during the CRRT and the fluid leakage, and we need to remove fluid more and more. What do you think about that? In terms of we focus in the fluid removal, but we also should pay attention on fluid intake that we should restrict also as much as we can.
I think to answer your question, I will refer to Ravi's explanation. So it's important that we keep an eye on the patient fluid balance. So it doesn't matter how much fluid the patient needs to receive, we are aiming for whatever negative fluid balance we plan for the patient.
Thank you. Thank you, Dr. Macedo.